Good afternoon and welcome to today's press conference. Bienvenue à cette conférence de presse. Today we have with us Health Minister Jean-Yves Duclos, Dr. Mona Nemer, the Chief Science Advisor, Dr. Michael Strong, President of the Canadian Institutes of Health Research, and Dr. Theresa Tam, Chief Public Health Officer for the Public Health Agency of Canada. My name is Mia Rabson and I will be moderating the press conference today. If you are online and have a question, please use the raise hand function. We will be taking questions in the room first, and I'm told we'll have about 30 minutes for questions after the statements are made, and we will start, I believe, with Minister Duclos.
Good afternoon, bonjour à tous et à toutes. Merci de me donner la chance de vous parler aujourd'hui en compagnie de mes collègues, les docteurs Tam, Nemer et Strong. Hospitals across the country are facing major challenges and emergency rooms are overwhelmed. Health workers are experiencing significant strain and are running out of steam. Canadians are extremely concerned, and so am I. Canadians, patients, caregivers, and health workers all want results, and we remain committed to working collaboratively with all our partners to do things differently. We will do so by focusing on the ends rather than the means, because as we can see now, the old way of doing things does not work. I remain committed to working with my provincial and territorial counterparts to improve health services for everyone. And that is why at last month's Health Ministers' meeting, I confirmed that we are ready to further increase healthcare investments through the Canada Health Transfer. In addition, we are ready to invest more in funding through tailor-made agreements with provinces and territories that will allow us to provide better care to Canadians. We owe it to Canadians to come together and find immediate and longer-term solutions to address those challenges. This brings me to my first update. Parents and caregivers have been particularly concerned about their difficulty to find children's analgesics. As of today, over 2 million additional bottles of these medicines have been made available to parents and caregivers through increased domestic supply and foreign importation. I can also confirm that the drug company Alon estimates that an additional 800,000 bottles for this month will be available at pharmacies and retailers across Canada. The influx of new products should help parents manage their kids' symptoms at home as we continue to experience a surge of respiratory illnesses across the country. With cold and flu season off to an earlier start than anticipated, we need to protect the overburdened health workers by doing everything we can to stay healthy, especially as we enter the holiday season. That includes staying up to date on our vaccinations. There are safe and effective vaccines available for both the flu and COVID-19, and these are available to everyone in Canada over the age of 6 months. And today is a great anniversary in that regard. 2 years ago, on that exact date, the largest vaccination campaign in the history of Canada was launched. 95 million doses of vaccines against COVID-19 have been administered since then. The National Advisory Committee on Immunization has also recently recommended that children 6 months of age and older can safely receive a COVID-19 vaccine at the same time as other recommended childhood vaccines, including the flu shot. This being said, we're still learning about COVID-19, and there remains much to learn about how it affects human health over the long term. What we do know is that even a mild COVID-19 infection or reinfection can cause real long-term consequences for individuals, communities, and our healthcare system. Evidence shows that almost 15% of adults who were infected with COVID-19 experienced longer-term COVID-19 symptoms. The nature and severity of these long-term effects can vary from person to person, and these effects are collectively known as post-COVID-19 condition, also referred to as long COVID. To support Canadians who are living with the longer-term effects of that virus, The Government of Canada is working with all experts to better understand this condition. In July 2022, Dr. Nemer, Canada's Chief Science Advisor, established the Task Force on Post-COVID-19 Condition to develop a scientific framework for managing long COVID. Pour soutenir les Canadiens et les Canadiennes qui vivent avec les effets à long terme parfois sévères de la COVID-19, le gouvernement du Canada travaille avec les experts pour mieux comprendre le syndrome post-COVID, aussi connu comme la COVID longue. En juillet 2022, la Dr Nemer a créé un groupe de travail sur la COVID longue. Les recommandations du rapport publié aujourd'hui identifient les mesures à prendre pour faire face aux répercussions sanitaires et socio-économiques de la COVID longue. Le rapport complet devrait être publié à la fin janvier. Je tiens à remercier la Dr Nemer et les membres de son groupe de travail pour tous leurs efforts. Les recommandations du groupe de travail guideront un plan d'action conjoint pour tous les partenaires et gouvernements afin de soutenir les Canadiens vivant avec le syndrome post-COVID. Depuis, puisque la science doit continuer d'être au cœur de nos prises de décision, nous investissons dans de nouvelles recherches sur la COVID longue. Grâce aux 20 millions de dollars octroyés aux instituts de recherche en santé du Canada dans le budget 2022, les IRSC ont lancé le 11 octobre dernier un appel à mettre sur pied le réseau canadien de recherche sur le syndrome post-COVID. Ce réseau interdisciplinaire ciblera la recherche relative aux effets à long terme de la COVID-19 sur la santé des gens et des systèmes de santé au pays et nous aidera à améliorer notre compréhension des conséquences sur la santé mentale et physique des gens qui en sont malheureusement atteints. En outre, l'Agence de la santé publique du Canada a reçu 9 millions de dollars pour soutenir l'élaboration et la diffusion de lignes directrices fondées sur des données probantes et d'outils d'application des connaissances liées à la COVID de longue durée. Ces outils reflèteront les impacts sur les diverses populations du pays et seront importants tant pour les cliniciens que pour les patients. Les effets du syndrome post-COVID sont troublants, surtout pour ceux et celles qui vivent avec la condition et dont la santé et le bien-être sont durement affectés. Mais une chose est certaine, la meilleure prévention est de prendre des mesures pour éviter d'être infecté. Cela inclut la vaccination, y compris les doses de rappel, et la mise en pratique de mesures individuelles de santé publique comme le port d'un masque bien ajusté et la prudence dans les endroits publics. Et cela m'amène au dernier sujet nécessitant une mise à jour. Le 1er décembre, nous avons ouvert le processus de demande de la nouvelle prestation dentaire canadienne provisoire pour fournir aux familles admissibles des paiements directs et non imposables. Les parents peuvent demander la prestation en ligne par l'intermédiaire de Mon dossier de l'Agence du revenu du Canada ou par l'intermédiaire du centre de contact avec la clientèle de la même agence ou simplement en cliquant sur canada.ca/dentaire. Jusqu'à présent, plus de 57 000 demandes ont été reçues pour un total d'environ 91 000 enfants, aidant ainsi beaucoup d'enfants à garder leur plus beau sourire. Ayant fourni des mises à jour sur plusieurs dossiers, je passe maintenant la parole à la Dr Nemer qui va prendre quelques minutes pour vous présenter les points saillants des travaux effectués par le groupe de travail sur le syndrome post-COVID et les recommandations qui en découlent. Merci. Thank you.
Merci, Monsieur le Ministre. Bonjour tout le monde. Over the course of the pandemic, evidence has emerged that some individuals who have been infected with the SARS-CoV-2 virus may develop long-term symptoms, suggesting that COVID-19 can develop into a chronic illness. These symptoms range from muscle pain, shortness of breath, and extreme fatigue to what's called brain fog, gastrointestinal issues, and even heart palpitations. Collectively, they've come to be known as post-COVID-19 condition, or PCC, also known as long COVID. We don't fully understand what causes certain individuals to develop PCC or what leads to the different disease manifestations. We don't know why women are twice as likely as men to contract it. We don't know why it can accelerate the onset of other chronic conditions like diabetes and heart disease. But it is evident that PCC is a serious condition that can have, at times, irreversible health consequences. In light of all this, as the Minister said, I brought together experts and practitioners from across the country to provide the government with advice on ways to address PCC in Canada. In developing the recommendations, which we are releasing today, we looked at existing scientific evidence and heard from healthcare providers and people with lived experience. We spoke with many people who are suffering life-altering physical impairments. Their stories were heartbreaking. One individual reported feeling trapped in their own body. Another said they were treated with disbelief in the workplace. Still others recalled feeling abandoned by their community. And several reported difficulty accessing healthcare and social support. Most had lost their job. And this is my other point. Beyond the health problems, PCC also affects the daily lives of people, from their ability to work, to caring for their families, to interacting with their communities. And this can have significant societal impacts. For example, estimates from the US suggest that 10 million people with long COVID could carry an economic cost of $3.7 trillion a year when you take into account lost quality of life, lost earnings, and higher spending on medical care. With 1.4 million people in Canada already reporting symptoms, it's not difficult to imagine the serious ramifications for our own economy. Clearly, the risk of the disease is not evenly distributed, yet its impacts will be universally felt. So what do we do? To start, we need to acknowledge that PCC is real, that COVID-19 manifests itself as an acute, but also as a chronic illness. À l'heure où plusieurs personnes ne veulent plus entendre parler de la COVID, we're all suffering to a certain extent from COVID fatigue, nous devons faire preuve de vigilance. Le risque d'infection et de réinfection par la COVID est toujours présent. Cela signifie qu'il existe un risque continu de développer le syndrome post-COVID. Les vaccins contre la COVID-19 réduisent considérablement le risque de développer des complications à long terme et contribuent donc à réduire la menace pour les personnes et la société. In addition to their well-known protective effects against severe COVID-19, it is now clear that vaccines also contribute to reducing the risk of PCC. Nous devons également mettre en place de meilleurs réseaux qui relient les chercheurs aux prestataires de soins de santé et aux patients. Cela permettra de développer des méthodes de collecte et de partage rapides et efficaces des données et des informations afin d'améliorer les soins aux patients. What we learn from addressing PCC will likely benefit a broad range of Canadians, including those suffering from other infection-associated chronic conditions, such as Lyme disease, a condition that may become more common due to climate change. With the SARS-CoV-2 virus still spreading and the healthcare system already overburdened, it is vital that we act now to care for affected individuals and protect many more from serious post-infectious complications. Thank you, and now I'll pass it on to Dr. Strong.
Bonjour à tous. I'm pleased to be participating in today's event alongside Minister Duclos, Dr. Tam, and Dr. Nemer. At the Canadian Institutes of Health Research, we've been heavily engaged in Canada's research response to COVID-19. We work closely with the Public Health Agency of Canada and our federal partners to identify research gaps and priorities. From the start of the pandemic, the government recognized the important role of research in mounting a response to this. That's why CIHR received significant dedicated funding for COVID-19 research beginning in 2020. We have used this funding to rapidly mobilize Canada's research community to generate evidence needed to understand the virus and to make decisions on how to best protect Canadians. As the pandemic evolved over time, so too has our research response. The first projects funded in the spring of 2020 focused on containment measures such as vaccines, diagnostics, and therapeutics. I think I might mention at this point, Canada was one of the very first countries in the world to mount a unified research program after that. We led in many areas. Later research has focused on the broader impact of COVID-19 on the health of all Canadians, particularly vulnerable groups such as children and seniors, and the impact of caring for COVID patients on our hospitals. To keep pace with the emergence of new variants such as Omicron, we funded the Coronavirus Variants Rapid Response Network, also known as COVARNet, in March of 2021. This network is composed of researchers from across the country who have produced vital information on the different virus variants to help guide our public health response and to prepare for future pandemics. As the Minister and Dr. Nemer have noted, post-COVID-19 condition is a serious issue affecting many Canadians. This is a new condition for which we are still defining its clinical features and determining how best to treat it and support the recovery of patients. It is critical that we focus our efforts on understanding this potentially devastating disease. As part of our ongoing research response, we have already funded some research on PCC, or post-COVID-19, that will contribute to this understanding of the condition. For example, we are funding the Canadian COVID-19 Prospective Cohort Study, or CANCOV for short. This study involves more than 2,000 patients in Canada's 4 hardest-hit provinces: Quebec, Ontario, Alberta, and British Columbia. The study will help us to better understand both short and long-term outcomes in patients and their caregivers. Today, Minister Duclos has announced an important new step in the evolution of our COVID-19 response. This is the creation of a new national network focused on post-COVID condition, as clearly alluded to by Dr. Nemer and her task force as being a need. This network will be supported with $20 million in new funding provided to CIHR in last year's budget. We designed the network to ensure alignment with the goals and actions outlined for research in Dr. Nemer's task force report. And as such, the objectives to the network are very focused. It will, first and foremost, provide a platform to strengthen Canada's capacity for research on post-COVID-19 condition. It will enable comprehensive and timely understanding of the biological, clinical, mental health, health systems, and population health impacts of post-COVID-19 condition. It will engage relevant stakeholders at the local, national, and international level to support coordination of research activities. And lastly, it will swiftly mobilize research evidence to support an equitable response to the post-COVID-19 condition. At CIHR, we launched a competitive process to create the network in October. This process was led by the Centre for Research on Pandemic Preparedness and Health Emergencies, an initiative of the government which is housed at CIHR. The Research Centre was set up to continue to address COVID-19 and to help us ensure timely research and highly trained experts are in place for future emergencies. We will be ready to announce the recipients of the funding of this network early in the new year. The work of this network will make a major contribution to achieving the vision of the task force report in supporting Canadians affected by post-COVID-19 condition and reducing its impact. Merci, and thank you very much.
Thank you very much. Bonjour à toutes et à tous. Nationally, SARS-CoV-2, influenza, respiratory syncytial virus, or RSV, and other respiratory viruses continue to cause significant levels of infection in our population. Very young and elderly people, as well as those with pre-existing medical conditions, continue to be at the highest risk of serious illness. While increases in respiratory virus-related illnesses are expected at this time of the year, co-circulation of these viruses is causing significant strain on our healthcare system. Partout au Canada, le SARS-CoV-2, la grippe, le virus respiratoire syncytial, ou VRS, et d'autres virus respiratoires demeurent la cause d'importants niveaux d'infection au sein de notre population. Les patients très jeunes, les aînés ainsi que les personnes souffrant d'une affection persistante sont toujours les plus susceptibles d'être gravement malades. même si pendant cette période de l'année, une augmentation des maladies liées à un virus respiratoire est attendue, la circulation simultanée de ce virus met à rude épreuve nos systèmes de soins de santé. Surveillance indicators, including clinical and wastewater testing, show that SARS-CoV-2 is still circulating across the country. And while we are past the peak of the last COVID-19 resurgence, it is too soon to let our guard down. In Canada, variations in population level of immunity and current global trends suggest that an uptick in COVID-19 could occur in the new year. In recent weeks, genetic sequencing data on SARS-CoV-2 viruses show continuing increase in immune-evasive variants, notably BQ1 and BQ1.1, while the previously dominant BA5 lineage variants are declining. With the increased prominence of these variants in Canada, at a minimum, we could see a slower decline and a higher plateau in the number of infections, as well as hospital admissions in Canada, as this respiratory virus season plays out. In terms of the other respiratory viruses circulating, RSV activity has leveled off nationally, and infections are declining in some jurisdictions. This means activity levels are now within the expected range for this time of year. In contrast, influenza is continuing to trend well above expected levels for this time of the year, but this varies across the regions. Most worrisome is the increase in influenza-related hospitalizations. The IMPACT network, which provides data on pediatric hospitalizations due to influenza, has noted sharp increases in multiple sites across the country. These data also suggest a shift to a higher proportion of hospitalized cases occurring in the 10 to 16-year age group compared to seasons prior to the pandemic. However, the highest cumulative hospitalization rates for influenza continue to be among children under 5 years of age. Currently, the weekly number of pediatric hospitalizations being reported is above levels typically seen at the peak of the influenza season. Tragically, due to this high number of pediatric cases, we're also seeing higher than usual number of ICU admissions and deaths due to influenza in children. Le plus préoccupant est toutefois l'augmentation des hospitalisations liées à la grippe. Le réseau IMPACT, qui fournit des données sur les hospitalisations d'enfants en raison de la grippe, a relevé des augmentations marquées dans diverses régions du pays. Ces données suggèrent également un changement vers une proportion plus élevée de cas hospitalisés chez les 10 à 16 ans, comparativement aux 16 ans précédents de la pandémie. Toutefois, le taux d'hospitalisation cumulatif le plus élevé pour la grippe continue d'être élevé chez les enfants de moins de 5 ans. À l'heure actuelle, le nombre hebdomadaire d'hospitalisation d'enfants déclarés est supérieur au niveau habituellement observé ou plus fort de la saison de la grippe. Malheureusement, en raison de ce nombre élevé de cas chez les enfants, nous observerons également un nombre plus élevé que d'habitude d'admissions aux soins intensifs et de décès en raison de la grippe chez les enfants. To date, laboratory data indicate that this year's influenza vaccine is a good match to circulating strains and therefore is likely to help protect against serious influenza disease. Influenza vaccine takes about 2 weeks to provide optimal protection, so as we rapidly approach the holidays, now is the time to get vaccinated if you have not already done so. Flu shots are available across Canada and can be given to adults, teenagers, and children as young as 6 months of age. The flu shot can also be given at the same time as the COVID-19 vaccines. There are now more options for COVID-19 booster doses for children 5 to 11 years of age, and the recent approval of a bivalent vaccine for this age group. If it has been 6 months or more since your last COVID-19 vaccine dose or COVID-19 infection, Getting vaccinated now will boost your level of protection going into the holiday season. Staying up to date with the recommended vaccines provides an important foundation of protection. The results of the first population-based survey of adults across Canada, conducted between April and August of this year, show that close to 15% of those with a confirmed or suspected COVID-19 infection experience longer-term symptoms or post-COVID condition, with almost half of these individuals experiencing symptoms for a year or longer. While ongoing studies are needed, there is emerging evidence that the risk of developing post-COVID-19 condition is reduced if you have received 2 or more doses of COVID-19 vaccine prior to infection. As we move indoors and gather to celebrate the holiday season, I encourage you to build on the foundation that vaccines provide by taking additional personal protective measures. Together, these measures can provide very good protection against COVID-19 as well as other respiratory infections. When planning a holiday gathering, consider the potential impact of respiratory illnesses on your health and social plans, the health status and risk factors of the people you're gathering with, and the places you'll be gathering in. Properly wearing a well-fitted, well-constructed face mask in indoor public spaces or crowded settings, and taking steps to take the best ventilation possible are layers of protection that can reduce everyone's risk. Lorsque vous prévoyez un rassemblement pour le temps de fête, pensez à l'incidence possible de maladies respiratoires sur votre santé et vos plans sociaux, à l'état de santé et aux facteurs de risque des personnes avec qui vous serez en contact et au lieu dans lequel vous vous réunirez. Le port d'un masque bien ajusté et bien construit dans les endroits publics intérieurs ou bondés, la prise de mesures pour assurer la meilleure ventilation possible constitue d'autres mesures de protection qui peuvent atténuer le risque d'infection pour tous. Our healthcare system continues to be challenged by the additional burden of all respiratory viruses this time of year. The impact, particularly on children's hospitals, has already been overwhelming in many parts of the country. This holiday season, let's do the best we can to make our wishes for health and happiness come true by taking actions to protect ourselves and others from respiratory viruses. Happy holidays, joyeuses fêtes. Thank you, merci, miigwech.
Thank you. We'll start with questions in the room with 1 question and 1 follow. And our first question will go to Laura Osman from the Canadian Press.
Hey there. My first question is for the minister. I wanted to jump off of what you were saying about the government's willingness to increase the Canada Health Transfer, and if I'm hearing you correctly, also explore more tailored bilateral agreements with the provinces. I spoke to Adrian Dix last night, who said that he's still not clear exactly what the government is looking for in order to get those negotiations moving forward. So I'm hoping that you can kind of pull the curtain back a little bit, explain to us exactly how these negotiations work and what conditions you've put to the province and kind of a timeline for getting those talks moving.
Thank you, and I will gladly do so, taking the curtains back, as you say. And that brings me back to the last year, during which we had 12 meetings at the health minister's level, obviously many more meetings between officials and many others. And during those 12 meetings, with the leadership of Minister Dix in particular and the leadership of other provincial health ministers, we made very serious and good progress on 2 big pieces. The first one was how to support healthcare workers, to retain them better, to recruit them, to recognize their credentials, to train them, and then on data. And because data saves lives, how we can have in Canada a modern health data system that provides data to healthcare providers, to nurses, doctors, specialist physicians, pharmacists, so that the data on people's health are available when these people end up in an emergency department, or they visit their physician, or they go to visit a pharmacist. So how do we make sure that that data supports their health and the work of workers? we were going to the Vancouver conference with great hopes that not only would we finally agree on all of that great work that Minister Dix and others had done, but also we would share that work publicly. Unfortunately, just a few days earlier, my health ministers received an order by their premiers not to speak about those results publicly. And that's an unfortunate thing, because before we come to the means that we need to achieve some ends, we need to agree on the ends and to speak publicly about them and the results that come from investing in workers and supporting patients. So where we are now is we're continuing our conversation. I've met all my health ministers. I've been speaking to them almost weekly in various ways, and we know we'll get to an agreement on outcomes at some point. But we need more work, and we need premiers to let us do that work.
Based on my conversation with Minister Dix, he was under the impression that he doesn't know what the federal government wants. And they might be willing to give it if they knew what the federal government was looking for. Is the ball in their court to come to you, or is it up to you to tell them exactly what criteria you're looking for?
The ball is in the Premier's court. At the health minister's level, we all agree. We've got a great relationship. We agree on the diagnostic. We agree on the problems and the solutions to those problems. We were in total agreement in Vancouver in private. The problem is that the premiers don't want us to speak about those outcomes and those results. They want to maintain a futile fight on dollars. And that's a futile fight because they ask for 35%. If you do the calculations correctly, we're already at 35%. If you do what premiers ask us to do, if you add the whole package, the cash transfers and the transfers that come with the tax points, we are at 35, roughly speaking. We were a bit above 35 during COVID-19, which we're roughly at 35 now, and we've been at 35% for the last 50 years almost. Now, in addition to CHT, the tax points, as we all know, we have been investing and we keep investing in the fight against COVID-19, $72 billion in total, plus all of the additional transfers for home care, mental health care, and long-term care, not even mentioning the $2 billion additional that we sent a few weeks ago to reduce backlogs in surgeries and diagnostics. So on the dollars, it's not a useful fight. If we were to only focus on 35%, we wouldn't do anything more. But the Prime Minister did commit that we would be investing even more in terms of resources. But we need to agree publicly and to speak publicly on the results based on the hard work that Minister Dix and many others did in the last year.
Next question by Valérie Bain from Radio-Canada.
Alors, plus tôt aujourd'hui, le chef du Bloc québécois a accusé le Parti libéral de prendre les patients, les Canadiens en otage par rapport au transfert en santé, étant donné que les discussions achoppent et qu'on n'a toujours pas d'entente, que c'est les provinces qui ont des besoins et que vous avez les ressources et que vous ne les donnez pas. Qu'est-ce que vous répondez à ça?
Bien, je réponds que si on parle des ressources financières, le gouvernement canadien en fait déjà beaucoup, et beaucoup plus que ce que, d'ailleurs, les provinces demandent. Le 35 dont les premiers ministres parlent, on est déjà là à 35 Quand on fait les calculs correctement, quand on fait la somme des transferts en espèces, qui passent par le transfert canadien en santé, et les transferts par le biais des points d'impôt, on est à 35 On était un peu plus haut que 35 durant la COVID-19. On est présentement à 35 Si on ajoute à ça le 72 milliards de dollars qui continue d'aider les provinces et les territoires à lutter contre la COVID-19, les investissements bilatéraux en santé mentale, en soins de longue durée, en soins à domicile, si on ajoute le 2 milliards de dollars qui est en train d'arriver dans les provinces et territoires pour réduire les retards en chirurgie, en diagnostic, bien, on voit là que les dollars, il y en a beaucoup, et beaucoup plus que ce que le gouvernement canadien envoie généralement aux provinces et aux territoires, sans parler du fait que dans quelques semaines, en mars, le transfert canadien en santé va augmenter d'un autre 10 Donc, ce n'est pas la bonne discussion à avoir. La bonne discussion à avoir, c'est quels sont les résultats que l'on veut atteindre ensemble. Et la bonne nouvelle, c'est que tous les ministres de la Santé, incluant moi-même, évidemment, on est d'accord en privé sur ce qu'il faut faire pour améliorer et même transformer notre système de santé, avoir un meilleur accès aux médecins de famille, retenir, recruter et former davantage de travailleurs en santé et reconnaître aussi les compétences des travailleurs qui ont été formés à l'étranger pour qu'ils puissent travailler ici au pays, réduire les retards en chirurgie et en diagnostic qui font beaucoup de mal présentement chez les gens, chez les patients, chez les familles au pays, et avoir un système de données moderne au Canada. On n'a pas un système de données moderne au Canada, on a un système de données qui est médiocre, qui mène malheureusement à des pertes de vie et à une qualité de soins qui n'est pas suffisante. Quand les médecins généralistes, spécialistes, les pharmaciens, les infirmières, les techniciens de laboratoire sont incapables d'échanger les informations entre eux, quand en 2022, on utilise encore des fax et des bouts de papier pour transmettre des informations sur la santé des gens, on n'est pas à la hauteur des besoins du Canada. Heureusement, on peut faire mieux et beaucoup mieux rapidement, et c'est ce qu'on a convenu de faire en privé à Vancouver, mais il faut que les premiers ministres nous laissent faire notre travail comme ministre de la Santé. Donc, nous obliger à ne pas parler de résultats, mais à focaliser entièrement sur les dollars, ce n'est malheureusement pas un plan en santé.
Mais le fait que vous ne vous entendiez pas et que ce soit un sempiternel débat, là, les gouvernements avant vous aussi, mais en ce moment, c'est vous qui en êtes responsable. Au final, les Canadiens sont pris en otage, là, peu importe c'est la faute de qui. Là.
Bien, pour les dollars, à nouveau, il y en a beaucoup et il y en aura encore plus dans les prochains mois avec l'augmentation du transfert canadien en santé. Maintenant, pour les résultats, comme je dis, la bonne nouvelle, c'est qu'en privé, tous les ministres de la Santé s'entendent sur ce qu'on doit faire ensemble. Mais en public, on n'a pas encore l'autorisation des premiers ministres des provinces pour en parler et pour focaliser sur ces résultats.
Kevin Gallagher, CTV News.
So if it's in the Premier's court, and the Premiers are saying the Prime Minister will meet with them, and the healthcare system's in a crisis, and as you acknowledge, the hospitals are in a crisis, what's the short-term solution to give any of these hospitals that are turning away patients or, transferring patients elsewhere some relief? Can the federal government do anything right now in the short term?
Well, the federal government, as I said a moment ago, has been sending, is sending, and will be sending very significant additional resources to support the difficult work of my colleagues' health ministers. Their job is not easy with the viral situation of which Dr. Tam spoke a moment ago. It's very difficult in hospitals and in healthcare contexts across Canada. So my job is to be an ally of health ministers, to make sure that that significant and additional funding that our government has been committing to is being received by health ministers. And that's the case with the $2 billion just recent investment in supporting our healthcare system, and more particularly hospitals, in the context of backlogs of surgeries and treatments. The equally important work that we need to do together is to look at the longer term. Our healthcare system has been under severe demographic pressure over the last few years, and over the next few years it will be under increasingly heavy demographic pressures. And to do that, to address that pressure, we need to have a more modern healthcare system, a healthcare system that invests, for instance, in sufficient access to family health teams. Lots of our patients now end up in a hospital because they don't have a family health team to go to. Or they end up in a hospital because, not having had an access to a family health team, they end up with more severe health conditions, and then it becomes a lot more complex and a lot more difficult and much more costly, and unfortunately a lot less good in terms of health care and health conditions, to end up in the emergency department as opposed to having been able to visit a family health provider prior to this. In addition to that, as I said a moment ago, it's about data and modernizing our healthcare system, making sure that safe and appropriate information on patients is accessible by healthcare providers, and investing in home care and mental health care and long-term care as we have promised to do and as we're doing now.
But you're saying the health ministers that you meet with agree with those reforms and changes that need to happen to the system. However, we're hearing from the provinces that they want to meet with the Prime Minister. They want to move forward on getting the healthcare transfers increased. So what's holding this process up? You're blaming the premiers. The premiers are blaming the Prime Minister. Where's the truth?
Well, premiers have important responsibility. Health ministers have an equally important responsibility, and we need to be given the room to take on that responsibility. We were able to do that. We were prepared to do that, and we were hoping to do that in Vancouver just a few weeks ago. Unfortunately, the premiers asked us not to do that work.
Sir, what can't you share, though? I'm confused. What is it that you can't share? The premiers aren't allowing you to share. I want to make sure I'm hearing you correctly. The premiers are forbidding the health ministers that you spoke with and have an agreement of some type to move forward with, not to share. Am I overstepping that? Am I misunderstanding something?
Yeah, as you said, and as you heard earlier, there were two key plans, one on supporting health workers and one on modernizing our health system, including having a modern health data system in Canada. We were prepared to approve those plans and to make them public, but we were asked by premiers not to do so.
Emily Bergeron, La Presse canadienne.
Bonjour, Monsieur Duclos, juste ici. Vous avez souligné que vous et les provinces ne s'entendaient pas sur le 35 %, sur le fait que vous vous dites qu'il est déjà atteint. Donc, est-ce que ça, la reconnaissance là, de votre calcul, que le 35 % est déjà atteint, est-ce que c'est une condition sine qua non pour aller pour cheminer dans des négociations? Puis, si oui, là, vous seriez prêt à aller jusqu'à combien de pourcents? 40, 45 % selon votre calcul? Et si ça, c'est pas une condition sine qua non, est-ce que c'est le partage de données? Parce que là, on a entendu M. Legault dire pas de problème, on va vous partager des données. Et si vous n'êtes pas capable de nous dire c'est quoi la condition sine qua non, alors qu'est-ce que les provinces doivent comprendre? Il y a peut-être pas un risque qu'elles pensent que vous cherchez sempiternellement des excuses?
Bien, là-dessus, il y a trois bonnes nouvelles. La première, c'est qu'effectivement, on est à peu près à 35 % quand on fait les calculs correctement. La deuxième, c'est qu'il y a des montants additionnels et substantiels qui s'ajoutent à ce 35 %, dont le 2 milliards que j'ai mentionné, le 72 milliards de la COVID-19 et les 3 milliards, 3 fois 3 milliards, parce qu'il y en a un pour les soins de longue durée, un pour les soins de santé mentale et un pour les soins à domicile. Et la troisième bonne nouvelle, c'est que le premier ministre a déjà dit qu'on allait en faire encore davantage. Donc, ce sont trois bonnes nouvelles du point de vue des dollars, du financement des soins de santé pour les provinces et territoires. L'autre bonne nouvelle que l'on doit vouloir générer le plus rapidement possible, c'est la bonne nouvelle sur les résultats. Qu'est-ce qu'on veut faire collectivement au Canada pour avoir des meilleurs résultats avec des investissements additionnels du gouvernement canadien? Et c'est là qu'on est rendu en matière de discussion au niveau des ministres de la Santé.
OK. Et on a entendu, là, je pense il y a environ 2 semaines, votre collègue Dominique Leblanc dire que, en mêlée de presse, ici à Ottawa, dire que il n'y a aucune province qui a un droit de veto sur la décision des autres provinces de conclure, par exemple, un accord bilatéral ou un accord seulement de certaines provinces avec le fédéral. Et c'est une question sérieuse parce qu'on pourrait en venir là à vous écouter parler quand on entend ce genre de discours-là. Alors là, dans le contexte où M. Trudeau va rencontrer M. Legault vendredi, si M. Legault a des inquiétudes que le Québec soit isolé dans des négociations, qu'est-ce que M. Trudeau peut dire à M. Legault pour le rassurer à ce sujet-là?
M. Trudeau va certainement dire à M. Legault, comme il me le dit tout le temps, que le gouvernement canadien doit toujours respecter la juridiction des provinces et des territoires de gérer les systèmes de santé dans ces provinces et dans ces territoires. Il serait inacceptable que le gouvernement canadien prétende qu'il est mieux capable de gérer le système de santé d'une province ou d'un territoire. Je suis sûr que c'est la première chose qu'il va lui dire, et c'est important, parce que c'est aussi ma première responsabilité, c'est de toujours le rappeler que je travaille dans le respect des responsabilités et des dures responsabilités de mes collègues ministres de la Santé des provinces. La deuxième chose, c'est que M. Trudeau va probablement lui dire aussi qu'on a une responsabilité partagée, des rôles différents, mais une responsabilité partagée parce qu'on sert les mêmes citoyens avec les mêmes dollars qui viennent des mêmes poches. Et en plus, on a au Canada une loi canadienne sur la santé qui oblige le gouvernement canadien à assumer une partie de cette responsabilité. Et la troisième chose, c'est l'accent sur les résultats. Parce qu'on sait que c'est ce que les gens veulent.
Mais excusez-moi de vous interrompre, mais la crainte, vraiment la crainte qu'il y ait des ententes à la pièce, est-ce que c'est une crainte qui est fondée?
Je dirais qu'au Canada, et on le fait en 2017, on le fait encore durant la COVID-19, il y a toujours le besoin de reconnaître la diversité de conditions et la diversité d'ambitions qu'on a naturellement dans une fédération. Mais c'est aussi mon rôle non seulement de le constater, mais aussi de faire en sorte que nos ententes avec les provinces et territoires tiennent compte de cette hétérogénéité de circonstances, de moyens et d'ambitions. Et je suis sûr que c'est ce qu'on va faire au cours des prochains mois aussi.
Ryan Tumulty, The National Post.
Yeah, this question might be better directed to the doctors, so the minister can take a time out. The report here, the executive summary, identifies that 1.4 million people have long COVID, that you don't know what causes long COVID in terms of the medical interaction there, and really don't have any idea how to treat it. I'm wondering in that context, where does the research begin to try to solve those problems? And is the money that the government has allocated so far anywhere near sufficient?
Maybe I'll start, and then perhaps my colleague, Dr. Strong, will want to add. We know that the post-COVID syndrome is due to infection by SARS-CoV-2, is due to the acute phase of the COVID. So this thing we know. What we don't know is what causes heart problems, for example, or cognitive problems to persist or to reappear weeks and months after the acute phase has resolved. Okay, so in terms of treatment, again, we mentioned that it's a complex disease, so you can think of the treatment in a way in three different buckets. One is treating symptoms that we know something about. For example, heart palpitation. For example, hypertension. For example, if there is a diabetes onset. The second one is treating mental health issues. We have at least treatments for that. The third one, which is the most vexing, is how do you treat ill-defined symptoms? So brain fog, for example, or chronic fatigue, or you get exhausted just from going to your medical appointment. And this is where we need a lot of research to understand what's going on. And we also need perhaps to try and see if any of the existing treatments for other diseases can be repurposed. And this is in the context of clinical studies. So Mike?
So again, thank you very much for the question. I might tackle it in three different components there for you. So your first one was with regards to how do we treat it? What was your second one? But I'll come at it first for that. Look, the very first thing that one needs to really be looking at in this is that the best treatment for this is the prevention of getting it. And that is crystal clear. We are starting to see very nicely from international data, and as Dr. Tam alluded to, getting the vaccine and having at least two doses of the vaccine actually does reduce the risk of going on to get the disease in the longer term. So the very first thing is that be vaccinated. We have highly efficacious vaccines. They do work. The second is that with regards to the actual causes behind it, we are beginning to understand this an awful lot more. But it is the first time that we've seen this illness. This is an incredibly unique scenario for us to have had an acute illness, as Dr. Nemer was referring to, that then becomes chronic consequences. So there are at least 3 reasons why we see the illness going into the post-COVID condition. The first one is that there is undoubtedly damage that is done at the time of the viral infection itself. So whether it be the heart, whether it be the lungs, whether it be the peripheral nervous system, doesn't matter. And that damage is lifelong in many scenarios, particularly for the lungs, right? So that's a concern for us. There is an immune response that is immediately mounted by this. This virus works to try and suppress the ability of the body to mount the immune response that would be required to kill it. And in doing so, it sets off an immune response that is not only immediate, but long-term. Add that to the damage that's already in place, so you have ongoing. The third piece of this is that the virus itself appears to be able to have longer-term consequences, particularly in some of the degenerative disorders, the neurological disorders with that. So if you take all 3 of those, I circle back to my first comment. We have never been in a scenario where we've been able to look and see the coming of a disease such as this and know that the way to prevent it is to be vaccinated. And so even if the vaccine primarily helps to reduce the load on the healthcare system, which is critical for it, our argument, and the thing that I would urge, and I urge my colleagues to do, is get vaccinated, not just because of that, but because it reduces the risk of these long-term. So we know a fair bit there, and we're beginning to understand the research. My very final comment on that is we are, as Canadian researchers, we have been incredibly fortunate in that the funding that we've received to look at this has been over and above all the other research that we do around health issues and allows us to work extremely closely with international groups that are doing exactly the same type of thing. So there's not redundancy. We're trying to understand this in real time. So it's a long answer, but it's a terrific question. So I hope I gave you what you're looking for.
And Minister, on healthcare and on these meetings with premiers and health ministers, you know, everyone in this room, I think, is having trouble understanding what happens next, because we have health institutions that are calling in the Red Cross to help out a children's hospital in one of the richest countries in the world. And we seem to have no movement from either side. I understand your desire for more long-term fixes to the healthcare system, but in the short term, the hospitals are overwhelmed. So what are you telling Canadians is going to happen? You're just going to wait until someone blinks?
Well, dollars are there. No, as I said, the CHT increased by 5% last March. We added another $2 billion just a few weeks ago. It will increase again by 10% in this March. We're sending other dollars for other things too, and it's never been as extensive in terms of financial support. And if it were only dollars, provinces and territories could also use their dollars. On average, they have a surplus now in Canada. So it's not about dollars. The dollars are there either from the federal government or within the coffers of provinces and territories. But even if that's not the case, the Prime Minister said that there will be even more dollars in the future and possibly quite in the short term, but for adjusting our system, transforming our system, making it more adapted to the reality of 2022 and beyond. When Canadians can't have access to a family health team, that brings Canadians to emergency departments. When healthcare workers are tired, exhausted, they leave, and once they leave, the patients cannot be cared for appropriately. When patients and providers can't share health data, then it leads to issues of safety and adequacy of healthcare.
David Thurton, CBC News.
Hi, good afternoon, everyone. My question is for Minister Duclos. Canada will receive another shipment of Paxlovid in the coming days. But based on the data that we've been looking at, the treatment has not been widely used. So what will your government do to boost the uptake and the use of Paxlovid?
Well, that's a great question, and there are 2 angles to that. The second angle, I'll turn to Dr. Tam to answer it, because there has been recent, I understand, recent evidence, biomedical evidence of the effectiveness of Paxlovid, which you might be interested to know more about. But on the first part, which is the accessibility, we have indeed sent hundreds of thousands of Paxlovid units over the last months. It started early in the winter, and we'll be there to share whatever provinces and territories required to care for patients. As you might hear from Dr. Tam in a moment, it has an impact not only of reducing the severity of acute COVID-19, but it can also have other benefits. But I'll turn to Dr. Tam for that part.
Thank you for that question. I think there's a number of things that we can do to increase Paxlovid use. It's correct that the federal government has sent, I believe, at least 700,000 doses to the provinces and territories. So I've been discussing with our colleagues and also the clinical care professional groups as to why and how, why Paxlovid isn't being mobilized as much as we think it could be utilized. There's several different factors, I believe. One is awareness for patients that this is an option. So I think we can collectively do more in that area, particularly those with high-risk conditions or seniors. Increasing their knowledge of how to access Paxlovid in their local area, but also the benefit of Paxlovid, which has been demonstrated not only in the clinical trials, but in real life now, that they can significantly reduce hospitalizations and deaths in high-risk groups, particularly in seniors. That group should talk to their physicians ahead of time. Get prepared, because if you get diagnosed with COVID, it may be a bit late to try and figure out where you can get Paxlovid, and you need to take it within a short number of days. So know how to get your rapid test and know ahead of time where you can get your Paxlovid is important. Healthcare providers, I think, have been a bit concerned about using Paxlovid because of the drug-drug interactions. We know that that can occur. But collectively, people can figure out which patients can still use Paxlovid. And I think increased awareness and education amongst health professionals is something that we can assist with. And then there is access, because you have to access a test and then the drug really fast. And you've seen in Ontario just recently that they've announced pharmacists can now prescribe Paxlovid after someone's got a positive rapid test. At the beginning, we didn't have a lot of supply, so people insist that you have to have a positive COVID test, and then in certain groups. And they've widened the eligibility in provinces now so that more people can get it and get it faster. I don't think that's the same method everywhere, but I think sharing best practices on how we mobilize it more, I think will be very helpful, particularly in seniors.
Just to follow up, we've budgeted some $2 billion for COVID treatments, including Paxlovid. Minister, are you concerned that there will be waste?
Dr. Tam, do we have evidence that has been wastage in the use of Paxlovid now?
I don't have specific numbers. All I can say is we have to follow the science on the evolution of the variants as well. Some of the most recent variants, BQ1.1, et cetera, are immune evasive. Those monoclonals don't work. So that will be regular need to not use them, because that would not be helpful to patients. So I think that's totally understood. So we now have antiviral agents like Paxlovid and also remdesivir that has to be given not by orally, so it's much more difficult to give potentially, but there are these options where the viruses have not eluded the drug effectiveness, and these can continue to be used. But we have to monitor susceptibility of the virus to these medications. And I do think that we mustn't let our scientific knowledge and biomanufacturing of these drugs go to waste, because we need to now adapt them to future use as well. But while I don't have the numbers, I think there's necessarily a need to park those drugs for now if they don't work.
I just want to add that this is a perfect example why data sharing is extremely important. The reason that pharmacists and physicians may be reluctant to prescribe Paxlovid, which for now is really the best game in town in terms of, an antiviral, other than, of course, the best, which is prevention, is because they don't have perhaps the full file of the individual. They don't know, what other diseases they may have had in the past, what other interventions they may have had, what drugs they're taking. And as Dr. Tam said, there are, known drug-drug interactions. So you don't want to, be providing something to an individual that may harm their health. So I thought that perhaps it's like a good example of why, this the sharing and the availability of health data is absolutely important for caring for individuals. Thank you.
Do you have another question, David? Raphaël Pirot from QMI.
Oui, bonjour. Écoutez, cette question est pour vous, M. Duclos. Donc, vous dites qu'on est déjà rendu à 35 % à peu près de financement aux provinces. Moi, ce que je me demandais, en fait, c'est tout simplement, est-ce que les PM des provinces, des territoires, est-ce que c'est une grande mascarade pour soutirer plus d'argent du fédéral? Est-ce que vous les accusez de jouer avec les chiffres? Qu'est-ce qui se passe, là?
Bien, je dirais deux choses. La première, c'est qu'il faut, reconnaître ce qui est déjà fait, et deux, reconnaître que le premier ministre canadien a dit qu'il y en aurait encore davantage qui seraient faits. Donc, quand on parle de reconnaître ce qui est déjà fait, c'est quand on fait les calculs correctement. On est à 35 % depuis à peu près 45 ans, un peu en haut, un peu en bas. Durant la COVID, c'est monté presque à 40 %. C'est dépendu maintenant autour de 35 %. Et en plus de ça, bien, comme je le disais, il y a des montants additionnels qui s'ajoutent. Donc, ça, c'est la première chose qu'on doit convenir. Mais on doit aussi dire en même temps que ce n'est pas l'objectif, ce n'est pas de faire une comptabilité. Les Canadiens et les Québécois ne s'intéressent pas à cette comptabilité. Donc, en mettant l'accent sur des points de pourcentage et des points d'impôt, je pense qu'on s'éloigne des vraies préoccupations des gens. Et ce qui m'amène à la deuxième chose, c'est que les vraies préoccupations des gens, c'est sur les résultats additionnels qu'on aimerait atteindre avec des ajouts du gouvernement canadien en termes d'investissement. Qu'est-ce que les gens veulent voir en termes de résultats si et lorsque le gouvernement canadien va ajouter encore à ses financements déjà significatifs? Et c'est là que la vraie discussion et la bonne discussion a lieu et doit avoir lieu.
Et moi aussi, ce que j'aimerais savoir, c'est il y a plusieurs premiers ministres qui ont déjà dit qu'ils allaient, par exemple, comme M. Dubé, mettre sur pied un tableau de bord avec des indicateurs. Peut-être que ça ne satisfait pas, c'est pas exactement ce que vous recherchez. Vous aimeriez peut-être quelque chose de plus central. Mais est-ce qu'une condition, en fait, pour finalement mettre un terme à ce débat-là, ça pourrait être tout simplement, vous devez investir l'argent en santé, et c'est tout?
Mais laissez-moi vous dire quelque chose. Le plan de M. Dubé en matière de données en santé, il est excellent. C'est exactement ce genre de plan qu'on a envie d'appuyer, non seulement à l'échelle du Québec, mais aussi ailleurs au Canada. Il y a des provinces qui ont aussi d'autres plans qui sont très bons en matière de données en santé. Les données, ça sauve des vies. Lorsqu'il y a des gens qui arrivent à l'urgence, puis le médecin ou la médecin n'est pas capable de savoir si ces gens-là ont été vaccinés, quels médicaments ils prennent, quels sont les récents tests qu'ils ont pu avoir sur leur santé. Ça met en jeu la qualité et parfois la sécurité des soins qu'ils reçoivent. Donc, ce n'est pas des rapports là, papier qu'on envoie en copie conforme, c'est des données concrètes sur des dossiers de gens réels que des provinces comme le Québec ont envie de rendre plus facilement accessible aux fournisseurs de soins de santé.
Si on serait rempli.
Bien, vous voyez à quel point on pourrait s'entendre rapidement si les premiers ministres nous donnaient la permission aux ministres de la Santé de convenir de ce genre de résultats ensemble.
Donc, on y est proche. On est près du but, là.
On était prêt à y arriver à Vancouver. Mais Vancouver, quelques jours avant, mes collègues ministres de la Santé ont reçu un appel de leur patron pour se faire dire de ne pas parler, de ne pas arriver à une entente finale et de ne pas en parler certainement en public.
Hey, we're now going to turn to Zoom. We'll have time for one or maybe two questions from Zoom, and we'll start with Mike Crawley from CBC.
Thanks for taking my question. My question is for Minister Duclos. You mentioned data saves lives, and one of the biggest concerns in the flu season, as Dr. Tam mentioned, is the impact on children. And there's a piece of data that we've been wanting to find out, which is the deaths of children from flu. British Columbia was transparent about this. They announced when there were flu-related deaths from children, but other provinces are not giving out information about children's deaths from the flu. So, Minister Duclos, what do you believe should be the policy here? Should there be transparency, or is it right to keep this information secret?
Well, let me first say that these deaths are tragic deaths. No, these are numbers, but more importantly, and much more importantly, these are real children, families, grandparents, and parents who are grieving the loss of those children. Having said that, yes, data saves lives. No, obviously we don't know whether it would have been possible to save those children's lives with better access to data. But as Dr. Nemer said a moment ago, and as Dr. Strong knows really well, and as Dr. Tam knows really well with her work with other public health officers across Canada, data does lead to better treatments overall, but also better treatments adapted to the conditions of the patients that workers are there to look after. And in Canada, unfortunately, we don't have a world-class health data system. We have a mediocre class data system, and we can do a lot better. The great news is that all health ministers agree that we should and must do better. And the equally great news is that we will be there, as the Prime Minister said, to support those efforts through increased supports to provinces and territories.
Well, my follow-up is for Dr. Tam. From the perspective of public health, is it best to publicize statistics around deaths from something like the flu in children for the purposes of, as British Columbia did, in then encouraging parents to get their children vaccinated?
Well, I think information is extremely important for informing the population about measures to take to protect themselves. So that is a fundamental aspect of public health, I think. One thing is clear that, of course, something like influenza we know happens every year, doesn't get as much attention or hasn't been paid as much attention as COVID has. We've gained some capacity from the COVID experience to show that we are capable of monitoring specific health information in real time. In the time of an urgent situation. So I think we can build on that experience. One thing that I do have to clarify is that children do get serious outcomes from influenza, although majority of them, if they rest up properly, can recover at home, but particularly the youngest kids. And we are also in a special situation that we're just coming into increasing contact post 3 years of reduction in contact during the pandemic. I think because the numbers are small, which we're grateful for, the numbers of deaths, provinces are often very careful about privacy. So even British Columbia, until you get above the number 5, it's difficult. We don't get that level of reporting nationally too, for the fear that individuals can get and identify very easily. That is something that we have to work through because that is important to individuals. But instead of data custodians, we need to be data stewards and manage appropriate data, but also informing the public so that they have the information that they need. Just while I have the mic, I did find the Paxlovid numbers, so we did allocate over 700,000 treatment courses of Paxlovid to provinces and territories, while we've procured 1.5 million courses. We have a lot of rapid tests that have been sent out. So together, in combination, these two measures can help reduce the impact of COVID-19, particularly in the high-risk groups.
Okay, and we'll take one final question on Zoom. Alice Gerard-Boisé from La Presse.
Bonjour. Les CDC des États-Unis ont annoncé aujourd'hui que la COVID longue a causé au moins 3 500 décès. Au Canada, on estime à combien le nombre de décès qui ont été associés à la COVID longue?
Dr. Strong or Dr. Nemer?
I think the simple answer is we don't know yet. You know, that's another area where data is unfortunately missing from across the country. It's very difficult really to, even the CDC in the US said that they believe these may be underestimates because there is no clear definition and medical sort of description. But here in Canada, I think that we're still figuring this out.
Certaines personnes ont désormais la COVID longue depuis plus de 2 ans, puis ils ne voient pas d'amélioration dans leur état. Il n'y a pas de traitement généralisé disponible au Canada non plus pour les aider. Donc, à court terme, comment vous comptez accompagner ces personnes qui commencent à perdre espoir?
Ben, justement, la raison pour laquelle donc nous avons fait part publiquement de nos recommandations et particulièrement l'importance de reconnaître que le symptôme existe, d'accélérer les informations à la fois au public mais aussi aux soignants eux-mêmes, c'est pour pouvoir aider à soigner ces individus-là. Je voudrais juste peut-être préciser que ce n'est pas juste au Canada qu'il n'y a pas de soins, il n'y en a pas ailleurs non plus. Donc, ce n'est pas une condition pour laquelle on sait comment faire, on est en train d'apprendre encore, et d'où l'importance que la recherche et la prestation des soins soient vraiment intégrées pour qu'on apprenne à fur et à mesure de nos propres expériences. En ce moment, il y a certaines provinces qui ont déjà commencé à mettre sur pied des cliniques multidisciplinaires où on a plusieurs spécialités de médecine. On a aussi de la réadaptation, des soins psychologiques également, etc. C'est vraiment un très bon début, mais il n'y en a pas suffisamment et l'accès pose toujours problème. Moi, je vous dirais, c'est d'où l'importance vraiment d'accélérer la recherche afin qu'on puisse plus rapidement offrir des soins et améliorer la qualité de vie de ces personnes-là. Puis, je ne sais pas si Dr. Strong aimerait ajouter quelque chose.
Really, I would simply echo what Dr. Nemer has been saying as well, too. But, you know, for those individuals who, you know, have symptoms that are persistent for that period of time, and you know, one of the issues behind all of this is that many of those symptoms can, in fact, look like you can be misdiagnosed in the sense of they are fairly subtle or they're cumulative look. So one of the first things that we recommend right off the top is ensuring that you are seen by a multidisciplinary team or by specialists in the area to make sure that this is not just simply ascribed to being PCC. So number one on that is kind of get it right and make sure that you're being looked after there. The second is that we don't have specific therapies that will bring a full stop to this right now, but there's a lot of symptomatic therapies that can be done, and Dr. Nemer started to allude to those. The final piece is that, like everything that you know we've looked at and had to face over the course of the last several decades of new diseases coming, it takes time and it takes research to get those answers, but this is the right direction. This is what needs to be done. So I'm encouraged that we're moving, and the report of Dr. Nemer is helping to guide us on that.
Thank you so much. This will conclude today's press conference.